friends, in this video we will deal about the basics of hematology. What we'll do is we'll start to understand how does the basic anemia and its concept stands for. We all know anemia is basically defined as a condition where the RBC number is less, because of which our body is not able to transport oxygen to the peripheral tissues. That what is how you define anemia from Robbins or any textbook language. But what is the basic concept of anemia? That means, how do you diagnose a case of anemia? Number one. How will you get to know that the patient has anemia, and from that how will you get to know what is the basic reasoning, that is whether the RBC has less production or whether it is more destruction of RBC to the patient. To understand this basic concept, this topic is RBCs and anemia. Okay, RBCs and anemia. Basically, when we talk about the RBC and anemia, we should first understand from where do these RBCs basically arise from. Those RBCs, they actually arise from bone marrow. So what I'll do is, to understand you the basic concepts here, on left side I am writing the bone marrow, on right side I will write the RBCs. Okay. Now what I will do is, we will try to understand that what are the cells from the bone marrow which actually goes to produce an RBC. So basically what we know is erythroblast makes RBC, but that is a very rough language. To understand this in detail, we should now know what are the types of erythroblasts in the bone marrow. Like, the first and the most immature is pro-erythroblasts. They are called as pro-erythroblast. Pro-erythroblast is the most immature erythroblast. So I will draw it large in size with a large nucleus, which is not very mature, it is immature nucleus. It will have a very light blue color nucleus, something like this. Immature will be light blue in color, and it also has a very light blue color cytoplasm, almost like this. Okay, it's a light blue color cytoplasm. This is a pro-erythroblast, which is the most immature form of erythroblast. Okay, the pro-erythroblast will then mature to become the early, also called as basophilic erythroblast. So now what happens, when the cells mature to the basophilic stage, the size of the cell decreases. Okay, so what I'll do is, I'll just draw a smaller version of the cell. The nucleus will be same blue in color. Cytoplasm again remains blue, and hence the name basophilic. And the nucleus, it matures a slightly bit more than the proerythroblast, like this. So why are we calling this basophilic? Because it's very simple understanding. The color of this cytoplasm here is completely blue, and hence we are calling this basophilic. Okay. From this basophilic, it then goes to become a intermediate. Intermediate is also called as polychromatic erythroblast. Okay, it is also called as polychromatic erythroblast. So what happens, the polychromatic erythroblast, the size will further reduce a bit, nucleus will a bit mature again, it will bit mature again, the size of the nucleus will become a bit smaller, so bring a slightly smaller nucleus. Now you see, the name is polychromatic. What is the meaning of the word poly? Poly means many. So what happens, the color basically is blue, but between this blue there is also a pink color here. There is also a pink color here, like this. So blue also and pink also, and hence the name polychromatic. There is blue also and pink also, and hence the name polychromatic, like this. Blue and pink, poly, two colors. Okay. Then the cell will then mature to become late, also called as orthochromatic erythroblast. Orthochromatic erythroblast. The size will further reduce, so does the size of the nucleus, but now nucleus will become very small in size, and look how dark it is appearing, how dark blue it is appearing. The color of the cytoplasm is completely pink now, and hence the name orthochromatic erythroblast. These names are very important. In fact, this year's JIPMAR question was, which is the most mature erythroblast, and the answer is late or the orthochromatic erythroblast. These all are the cells what you will find in the bone marrow. These cells will then mature to become the cells in the RBCs. Let us see what are those. So, what I will do is I will just draw a shaded line here to differentiate the two areas, that is bone marrow and the erythroblast. The later is erythroblast, it will then mature to become a cell called as reticulocyte. Reticulocyte. Reticulocytes, they are further small in size, and what happens, friend, is whenever the cells are coming out of the bone marrow, they are passing through the spleen in the peripheral blood. So, spleen removes the nucleus, okay. Spleen removes the nucleus. So, now the cell that you have drawn, that is reticulocyte, it won't have the nucleus, right. What it will have is, it will have a just pink cytoplasm and may have very light bluish stain to it, very light bluish stain. I am not drawing that, but because there is very light bluish stain over this pink color, the name would be called as polychromatophil, okay, polychromatophil. Well, reticulocyte, it will then mature to become a mature RBC, or you can simply write an RBC. RBCs are further small in size and the color of cytoplasm is blue like this, sorry, pink with a central pallor. This cell is called a RBC, okay. This cell is called a RBC. This cell is called a RBC, okay. Now, when you look at all these aspects together now, what we can now deduce here is the cells, okay. The cells here, what you are writing here, they are proerythroblast, then there becomes polychromatic, then becomes orthochromatic. The orthochromatic will then becomes a reticulocyte. Reticulocyte will then mature to become a RBC. This is a basic thing. Now, the many questions that is asked here. Number one, where do you think is the hemoglobin happening? So, for that you should now understand what is the basic reason of the pink color appearing here. The pink color is appearing basically because of hemoglobin, and that is the reason. It is a very simple question now. Hemoglobin is first visualized at what stage? The answer is intermediate or polychromatic erythroblast. We will write the question number 1 here. Hemoglobin first appears in which stage? Answer is intermediate, also called as polychromatic erythroblast. Intermediate or the polychromatic erythroblast. Intermediate or the polychromatic erythroblast. Okay, that's one thing. Secondly, what you should understand here is what is happening as the cells are maturing. Again, a PGI question. As the erythroblast matures, the size of the cells is obviously reducing. Nucleus size reducing, and cytoplasm proportion is increasing. That means this is the second MCQ asked here. During erythroblast maturation, what happens is the size and the size of the cell and the nuclear size, cell size and the nuclear size, they both decreases. Very clear? They both decreases, and in proportion to the nucleus, cytoplasm size is increasing. Okay. Now, you might be wondering, so why are you teaching this? Why don't you directly start with anemias? The reason is very clear. See, what is anemia, friends? Anemia basically is a condition where this RBC number is less. You all agree? When will this RBC number reduce? A simple logical reason is, number one, if the cells you see here, there is a blast, you see here, all these blasts will reduce in number, number one, okay. That means it is a case of hypoproliferative anemia. That's it. A second reason can be, if this RBC in the peripheral blood, this RBC is reducing. If this RBC is reducing, what will happen is, because of the reduction in this RBC number, what will happen is, there will be a reason of this would be hemolytic anemias. Why? Because the cells are coming into the peripheral blood and in the peripheral blood the cells are getting destroyed. It may be a simple case of hemolytic anemias. Okay. Now, how will you differentiate them? Again come to the basic things. Number one, if the blasts are less here and the RBC is less here, then reticulocyte number will also be low in the peripheral blood. Okay. Secondly, if the destruction of RBC is more in the peripheral blood here, the erythroblast will compensate to produce more cells. So, all the blast in this area will be increased. What will happen is, because the blast here will be increasing, reticulocyte will also increase just for compensation. But when they become RBCs, the number will be destroyed and will therefore reduce. So, what is the next best test for a anemia diagnosis? Well, you can obviously count the number of blasts, but for that you have to take a bone marrow aspiration. It's a very painful procedure. So, what you preferably do is you just count the reticulocyte number in the peripheral blood. If reticulocyte number is less, that means production has been less, and hence a case of hypoproliferative anemia. However, if there is reticulocyte has increased, you can say destruction of RBC is more. That is a case of simple case of hemolytic anemias. So, there is where you start your concept building in hematology. My concept you should write here is, whenever you get a case of anemia, okay, approach to a case of anemia, approach to anemia. So, what we will do is next test is peripheral smear and reticulocyte percentage. Peripheral smear, PS means peripheral smear, okay, and reticulocyte percentage. Now, based on the retic percentage, if your retic count or retic percentage, retic means reticulocyte, okay, is low, you can say it is hypoproliferative anemia, okay. And if your retic count is high, if it is high, it's a case of hemolytic anemia. It's a case of hemolytic anemia. Reticulocyte count is high, it means it is hemolytic anemia. Clear? So, I think we should now understand what basically is this reticulocytes. So, our next topic would be reticulocytes. The short form I have been using for this is Retic. Okay? Reticulocytes, obviously they are immature RBCs. They are immature RBCs. Some books can write them as juvenile RBCs. Juvenile, that means children. Okay? So, they are immature RBCs. Do they contain nucleus? No, they do not contain nucleus. If they do not contain nucleus, why did I say that there is some bluish color that is happening there? The reason of that is they have some ribosomal RNA. So, they do not contain nucleus, but they contain ribosomal RNA. They contain ribosomal RNA, short form rRNA, ribosomal RNA, that is rRNA. Okay. Next, because they contain ribosomal RNA, what you should also understand is the reticulocytes, they are also called as AKA polychromatophils. Why? Because this RNA will give them light bluish color, and hence the reason they are called as poly. Poly again means many, polychromatophils. Okay. Now, what is the count and how do you count them and how do you stain them? To stain them, you need a special stain called as Supra vital stains. Example of supra vital stains are, example of the supra vital stains are A, they are the methylene blue, better called as new methylene blue. B, brilliant crescile blue, brilliant crescile blue, and C, there is crystal violet. So the three stains, okay, crystal violet. Now, when you stain with them, what happens is, if you look at a normal RBC, will stain something like this. So what I am drawing is, I am drawing a RBC which is blue in color, and again will have a central pallor, but a reticulocyte will be larger than this, will not have any central pallor, and reticulocytes, they will also have a dark bluish color to it, a dark blue dots, like something like this. So this type of cell is a reticulocyte. Let's mark this. This is a normal RBC and this is a reticulocyte. This is how you diagnose them in an actual case scenario, in a smear. I will just show you the images also. Now what you do is, see, this is how you see a normal RBC. You can very clearly see the central pallor. So why do RBCs have a central pallor? The reason is very simple. RBC have central pallor because at the center you don't find any, neither you find any hemoglobin nor you find the nucleus. So central area is very clear, and that is the reason they are very white in area. This white area, because they don't have nucleus nor hemoglobin, it is called as central pallor. Okay, central pallor. Now look at this cell. This is a reticulocyte. All of these other cells are RBCs, in which this, you can see this dark staining cell here, the dark blue stain. This dark blue stain you see here, this one, this dark blue stain you see here, this basically is a reticulocyte. Okay, it's a reticulocyte. Now this again is a other image of reticulocyte, is very clearly seen. And what you do now is, you count the number of reticulocyte per 100 RBCs. 100 RBCs. That means, let's assume in this whole image, let's assume that there are 10 RBCs. Okay. So what I'll do is, I'll count the number of reticulocytes, which is like 1. See here 1. This is the 1. There is 2. There is 3, and you see this one is 4. Okay. There are 4 of these RBCs. So because there are 4 of these RBCs in the 4 of reticulocyte in the 10 RBCs, the number would actually come to be 40%, right? So reticulocyte percentage is counted as retic per 100 RBCs. The normal percentage would be 0.5 to 2%. It is usually in adults. Up to 5% is taken normal in children. Okay, up to 5% is taken as normal in the children. Okay, now having understood this, we now move to the next one. A high retic count indicates what? A low retic count indicates what? Obviously, a high retic indicates what? It indicates hemolytic anemia, and low retic indicates what? It indicates hypoproliferative anemias. Now, the problem is, if you say that this is the retic I have counted, what happens in hemolytic anemia is, your RBC number is already very low. Your formula is retic by RBCs, right? In hemolytic anemia, the RBC number have already reduced. So always you will get a very falsely high retic count. But the basic reason of counting a retic percentage is to know whether bone marrow is producing more cells or not. Got the point? The main reason is whether bone marrow is producing and releasing more retic or not. But in case of hemolytic anemias, because the RBC number is less, you will always get a falsely high retic percentage. And that is the reason you need a formula to correct reticulocyte count. It is called as corrected reticulocyte count. Okay, let's understand what is this formula. Corrected reticulocyte count, CRC. This is equal to percentage retic into hemoglobin or hematocrit of the patient divided by hemoglobin or hematocrit of the normal person. Okay, retic percentage into hemoglobin or hematocrit of the patient divided by hemoglobin or hematocrit of the normal person. This is equal to the corrected reticulocyte count. So, in a way what we can say is, this is taking an example, if you say retic percentage is say 40% and hemoglobin of that person is 5 gram percentage. Well, all you know that the normal hemoglobin is around 14 to 16 gram percentage. You know this? So, let us take a mean value of 15. So, when you want to calculate the corrected count, corrected CRC, it becomes 5 multiplied by 5 multiplied by, what is the hemoglobin? Sorry, retic is 40. So, let us take it 40 here into 5 divided by 15. This becomes how much? 1 and 3, and 40 by 3 would be like 13.3%. So, from the 40% is now reduced to 13.3%. So, this is what you take into account. Value is what you take into account when you basically see a patient is hemolytic anemia or he has hypoproliferative anemia. So, always you try to correct reticulocyte percentage and then you interpret it accordingly, always. Okay? This is the basic concept and the rule. Let us move to the next level. Often, to describe an RBC, you get something called as RBC indices. You might have heard about some RBC indices like MCV, MCH, MCHC, all of those. Let us understand what does it mean here. First, MCV. The full form you all know is mean corpuscular volume. Well, the normal value is around 80 to 95 femtoliter. Okay, normal value is 80 to 95 femtoliter. Okay. Second is MCH, mean corpuscular hemoglobin. Normal value being 30 plus minus 3 picogram. Pg means picogram. What does it basically mean? What is the basic concept behind it? It means hemoglobin per RBC. So, one RBC has how much hemoglobin? This is what it basically means. What do you think it means? How will you calculate this? Calculation of MCH would be, if you divide the total hemoglobin by the RBC count. Simple concept. If you divide the total hemoglobin of the patient by the total RBC, you will get hemoglobin per RBC, isn't it? A simple formula. Third, MCHC. MCHC basically means, by full form is mean corpuscular hemoglobin concentration. Mean corpuscular hemoglobin concentration. The normal value being 32 plus minus 2 gram per dl, and MCHC it is divided as hemoglobin divided by the packed cell volume, PCV. Why? Because what is basically hemoglobin? Hemoglobin per unit RBC volume is what is MCHC. So, I am deriving this formula by dividing the hemoglobin by the total volume of RBC. And what is the total volume of RBC? It simply is packed cell volume. Okay. Fourth, RDW, red cell distribution width. Red cell distribution width, RDW. It basically is a measure of an isocytosis. It's a measure of an isocytosis, which basically means variation in size. It means variation in size. Okay. So, simply if you take this, what does it mean is, I am drawing 3 cluster of RBCs. One of these normal RBCs like this. One are these small microcytic RBCs. And one are these type of RBCs, different shape and size. Now, if you look at the first cluster, let us call this A, this is normal, B is microcytic, and C, it definitely shows an isocytosis. Well, if I say which of them has maximum variation in size, obvious answer is C. There is no doubt, this has the maximum variation. But when you compare this one to these two, what you can say is, in the first one, the RBC number is okay normal, but what is happening is the slight variation is still there. You can definitely not say that all the RBC in this cluster is exactly same in size. So this is small and it's a bit larger. So definitely there is small variation in the size of the RBCs. Therefore, the RDW is 12 to 16. Small variation is always there. This 12 to 16 does not have any unit because it basically is a coefficient of variation, the statistical term which is derived from standard deviation. Okay. The microcytic may have again normal 12 to 16, and aniso it will have more than 16. That means, what does RDW measure? Does it measure the small RBCs? No friends, it only measures variation in the size of RBCs. Many students make this wrong concept that it is microcytosis in which the RBC RW will be increased. It might be only if there is an isocytosis with microcytosis. Okay? Okay. The next one. The fifth one is PCV, also called as hematocrit. PCV, as you all know, is packed cell volume. Packed cell volume. So it basically means volume of all the RBCs packed together. So how will you derive this? A simple formula or simple calculation would be taking a Winthrop's tube. Take a Winthrop's tube like this. In the Winthrop's tube, you can just fill the blood in it like this. Okay, I have put the whole blood in it, and then you centrifuge this. After centrifugation, you will clearly see three areas. In the central area, all the RBC will settle below like this. Then above this there will be WBCs called as buffy coat, and over this there will be all plasma lined up. All plasma will be here like this. Now, if you take the ratio of this RBC, let us call this as A, and this whole Winthrop's tube volume as B. A by B is the packed cell volume. A by B is the packed cell volume. So this is the PCV, which is A by B into 100. Well, normally it is 40 to 45%. Normally it is 40 to 45%. That means in normal cases the volume of RBC will take 40 to 45% of the entire whole blood volume, okay. Now, once we understood these basic concepts, let us move to the next term. We now move to, okay, one more thing. Can you derive a formula to calculate PCV? Well, what is PCV? Look at this simple experiment. PCV basically means A, the percentage of A among the B. What is A? Volume of all the RBC taken together. Volume of all the RBCs taken together. Volume of all RBC taken together would be packed cell volume. So, a formula of the hematocrit will be MCV, that is volume of one RBC into the RBC count. This can be the formula of hematocrit. Okay, very clear? So, now from this we now move to anemia. By amount or by the amount of hemoglobin that you can say, normally hemoglobin is 14 to 16 gram percentage. This is a normal hemoglobin. This one is a normal hemoglobin. Now, what you can say is, when the hemoglobin is low, we can say by World Health Organization cutoff, the WHO cutoff for hemoglobin is less than 13 gram percentage for an adult male, less than 12 gram percentage for a female and less than 11 gram percentage in pregnancy. Okay, this is what you derive as the cutoff of hemoglobin as the World Health Organization says. So now when you know this, we can now derive how do you classify a case of anemia. Okay, classification in a case of anemia. According to the World Health Organization, WHO, classification, anemia can be classified in three ways. Number one, there can be increased blood loss. Let's call this A. B, increased RBC destruction. Let's call this B. And C is reduced RBC production. Let's call this C. So the three types of anemias: A, when there is more blood loss; B, when there is more destruction of RBCs; and C, when you can say when there is a reduced RBC production. Okay. Now, when you call something as increased blood loss, there can be simple two reasons of increased blood loss. Number one, it can be a acute blood loss or can be a chronic blood loss. Okay. Any case of increased destruction is called as hemolytic anemias. Hemolytic anemias. This you can classify into two ways, can be intravascular or can be extravascular. And C, decrease RBC production, it can be again of two types. Number one, it can be nutritional or can be a case of hypoproliferative anemia. Hypoproliferative anemia. So this is how you basically define or classify a anemia case. You can describe anemia into three headings. Number one, increased blood loss. Number two, increased destruction of RBCs. And number three, decreased production of RBCs. When you talk about a case of increased blood loss, it can be an acute or a chronic blood loss. When you talk about a case of hemolytic anemias, it can be either in the vessels or can be outside the vessels. Or when you talk about a case of decreased RBC production, it can be either nutritional or can be hypoproliferative anemia. Now, this is where we start with the different types of anemia. This was just a basic introduction to the classification of anemia as to what is anemia, how do you understand anemia, and how to basically describe anemia to three headings. Like from here you can guess that if a patient has more blood loss, the first one, obviously the bone marrow will compensate more. So retic count in the first one will definitely increase. Second, increased destruction of RBCs, retic count will definitely increase. But when you get a third case, you will definitely say the retic count has reduced. This is how you understand the types of anemia.